We're starting a new chapter here today, chapter 21, resuscitation. So in this chapter, we're going to identify what exactly happens inside the body during a cardiac arrest, how we're going to do our assessment and move forward with our patient care, and what can we do to improve our cardiac arrest survival. You guys have had your American Heart, CPR, and we're just going to kind of build on that, get a little bit deeper here. So let's talk a little bit about the pathophysiology of cardiac arrest. We know that the heart is a pump, and that's really its mechanical function. It's to push blood throughout the body. Now, the heart also has an electrical function, and this is when we hook them up to the cardiac monitor, and we can see that little rhythm show up on the monitor. So these two functions have to work together, because if they're not communicating and working together, then we don't have any actual cardiac output or any blood flow. So electrical stimulation causes the muscle to contract, and when the muscle contracts, it's going to force the oxygenated blood out into the body, and it's going to push it through the arteries to get to the rest of the body. Since the heart has two functions, if either one of those functions fail, that can lead to a cardiac arrest. So mechanical failure is going to include things like loss of normal heart muscle structure, an MI or a heart attack, chronic hypertension, because this puts excess stress on the heart, loss of normal heart valve function. The valves, if you recall from anatomy and physiology, prevent backflow of the blood. And if we have a lot of backflow, then we don't have a lot of forward pressure and volume, and so again, our cardiac output is decreased. Direct trauma can affect that mechanical function, and pulseless electrical activity can also be a mechanical failure of the heart. So on the electrical side, if we have issues with the heart, the cardiac conduction pathway coordinates all that electrical conduction through the heart. So if there's a problem with the pathway, there's going to be a problem transmitting that electrical impulse. Asystole is a complete failure of the electrical system. Asystole is seen on our monitors as a flat line, so if you think about it, there's zero electrical activity. The SA node, the AV node are not firing. There's no other electrical impulses traveling anywhere within the cardiac muscle. Now, when we have disruptions of the heart's electrical function, we usually see a dysrhythmia, and a dysrhythmia is a bad rhythm. Okay, dysrhythmia means it's not normal. When we're talking about cardiac arrest, we're usually seeing patients in a ventricular tachycardia or ventricular fibrillation, and those dysrhythmias can ultimately cause zero cardiac output, and the patient needs to be resuscitated. A couple other dysrhythmias that you may see or be able to identify are those rhythms that are unusually slow or those that are unusually fast. I've mentioned VTach and VFib, but when we're talking about fast and slow rhythms, you may be able to feel a carotid pulse or auscultate heart sounds. All of these dysrhythmias can lead to cardiac arrest. It's important to hook up your AED and be ready to shock if it is needed. Ventricular fibrillation and VTach are correctable, and these are the patients that you're likely to be able to resuscitate. When we talk cardiac arrest, there's sudden cardiac arrest and there's asphyxia cardiac arrest. And sudden cardiac arrest is going to be those rapid onsets of those dysrhythmias. There is a condition called commotio cordis. This is when you have an acute blunt trauma to the chest, and it hits the chest just at the moment of repolarization for the ventricles. And so it has to be at exactly the right time of the heart being at a certain part of the rhythm for this to occur. So it doesn't happen very often, but that can cause sudden cardiac arrest. And then also oxygen levels are usually pretty close to normal at the beginning of the cardiac arrest if it's sudden. And that's because you didn't have a oxygen deprivation type of issue that caused it. So it's usually related to the heart itself and how the heart responds to different elements. Asphyxial cardiac arrest is related to oxygenation and respiratory. So this would be, for instance, when the heart stops due to hypoxia. We get low oxygen levels in the blood, and with those low oxygen levels, we cannot feed the heart muscle, so that can cause an asphyxial cardiac arrest. A lot of times with asphyxial cardiac arrest, you're going to see more signs and symptoms with your patient, and so you've got a little bit longer of a warning, if you will, to try to correct it. Quality ventilations are going to be extremely important if we're concerned that this was an asphyxial cardiac arrest, because we know that oxygen levels have been low and we're trying to restore that oxygen to the cells. Agonal respirations are unique because in the medulla, where our respiratory center is, that is getting a little bit of oxygen, enough to keep it somewhat functioning. And so it's telling the body to try to breathe, but there really isn't enough there to make those respirations able to sustain life. So we know that breathing is a very primal reflex, again controlled by the medulla. Agonal respirations are usually irregular and they are shallow. When we see agonal respirations, if we don't intervene quickly, then this patient will continue to worsen until death and cardiac arrest occur. So let's break it down. We know that cardiac arrest is when the heart fails to pump. So we're no longer circulating blood. The blood gets stopped. When this happens, the cells are robbed of their oxygen and nutrients, and the organs begin to become damaged and stop functioning. When the organs fail, then the organism will die if this does not get corrected. The goal is to intervene as early as possible. So when we look at this, we have to think cell death leads to tissue and organ death leads to system-wide death and overall death of that individual. When we talk about pediatric cardiac arrests, understand that most kids have a pretty healthy heart unless they've got some type of genetic issue. So when we're dealing with pediatric cardiac arrests, they are primarily asphyxia in nature. This could be caused by choking, shock, or other respiratory problems, such as asthma. But cardiac arrest in children is usually a predictable outcome after steady decompensation. So what I mean by that, again, is when we're dealing with asphyxial cardiac arrest, we're dealing with a longer process. So we're seeing signs and symptoms, we're seeing the patient deteriorate, and if we don't intervene, they will develop cardiac arrest. This gives us time to react. When you're looking at your patient, think about what's going on. Be sure you are focused on the patient. You are doing what you need to do here and now in the present. While you are working with that patient, though, please do not forget your situational awareness. This is the idea of keeping in mind what's going on around you. We've talked about scene safety before, and we know that the medic's safety is our primary concern. if something starts going down around us and the scene becomes unsafe, we need to be able to react to that quickly. So as we're walking up to our patient and we're getting that general impression, we're kind of looking at the patient, we can tell by their body positioning, by the look on their face, or how they are posturing with breathing, how things are going for them. If we get to that patient though, and we find that they are unresponsive, they are apneic or not breathing, and they are absent of a pulse, we've got to intervene quickly. When cardiac arrest is identified, chest compressions must begin. Sudden unexpected infant death syndrome is a condition in which you may be called to respond to. The most common types of SUID are sudden infant death syndrome, also known as SIDS, sometimes a completely unknown cause. Even upon autopsy, nothing is found, and accidental suffocation and strangulation in a bed. And this can occur sometimes if you've got extra blankets, stuffed animals, pillows, and that in with a small child. What happens in these SUIDS issues is we have a continued slowing down of the heart rate, or we might see sleep apnea. Eventually, this infant will stop breathing altogether, and if not found quick enough, they will not breathe again. So this can be fatal, and many times is, because it happens during sleep. So it may be during a patient's or the infant's nap time or in the middle of the night when this occurs. You may come across this in your career. You may be called to a home for an infant who is unresponsive due to SUIDS. If this is the case, please remain professional. We need to provide emotional support to the parents or the caregiver. As I'm sure you can understand, it's likely they will be very upset. Most of the time, we're going to attempt resuscitation on these infants. However, if they are cold and stiff, rigor mortis has set in, and our resuscitation is not going to be successful. So if we know it's not going to be successful, then we don't continue in that direction. We need to be able to provide support to the parents or the caregiver and let them know the situation. So this is the chain of survival here. We've got 5 elements: recognition and activation of the emergency response system, high quality CPR that begins right away, early defibrillation. Those patients who have VTAC or VFib, the sooner they can get defibrillated, the better their chance of survival. Basic and advanced EMS scope of practice care, and advanced life support along with your post-arrest care should you get ROSC. Now we're going to talk a little bit about each of these in the next coming slides here, but it's all about teamwork. It's all about coordinating our efforts for the best outcome of the patient. So recognition and activation of the emergency response system. This is going to be the individuals that are on scene, and they need to initiate 911 so that medics can be dispatched. If there's anyone on scene that has appropriate training, they may be able to recognize cardiac arrest. They may be able to begin that resuscitation, as well as notify EMS. Dispatcher-aided CPR or pre-arrival instructions can be given, and that is going to help the bystanders to begin cardiopulmonary resuscitation. EMTs can participate in public CPR trainings. We know that not everybody gets certified in CPR, but many people have seen it done on TV or somewhere, and they recognize what the steps are and how to attempt to help this patient. In CPR, remember, we are compressing the heart to try to get blood to circulate throughout the body. We're also providing ventilations so that we can get oxygen into the cells that we are trying to circulate. CPR is going to supply oxygen to really only the core body organs. So this is cerebral perfusion and coronary perfusion. The rest of the body is probably still going to show signs of shock, like pale skin, but getting blood flow and oxygen to the brain and the heart are the most important. In CPR, you learned about hand placement. Understand that the heel of one hand should be on the center of the patient's chest, the lower third or so of the patient's sternum. With children, we may or may not need the second hand on top of the first to do our compressions. Remember, with adults, we're pushing deeper. With infants, we are going to use 2 fingers or our thumb encircling technique. When we talk about CPR, we talk about hard and fast. So our compressions need to be at least 2 inches deep in an adult. We do have to allow for complete recoil of the heart in order to allow it to refill with blood so that our next compression actually has a decent cardiac output. Spending half of each compression on that downstroke and half on the upstroke so that we keep a very rhythmic pattern. Now for infants and children, we don't push quite as hard. We're going to compress 1/3 of the anterior posterior diameter of the chest. So again, the infant laying on a hard surface, we're going to compress the chest 1/3 of that AP diameter. Compressions are going to wear you out, especially if you aren't doing them properly. So again, you've got the heel of one hand on the sternum, the other hand is overlapped, and the fingers are usually interlocked to help maintain control. The elbows should be locked and our shoulders should be over the sternum. Basically, we're trying to create a pivot point at the waist so that our entire upper body is working this compression and not just our arms. Compress no longer than 2 minutes and then switch so that you don't become tired. This allows for better rest for the medics who are performing the CPR, and we know that with prolonged CPR compressions by one medic, they get sloppy. They start to become less effective because the EMT is no longer able to provide quality compressions. This is a great picture showing how our pivot point, our fulcrum, is at the hips. We are placing our shoulders above the sternum of the patient, allowing us to use our whole upper body in doing those compressions. Elbows are locked, and we are going to be doing 30 compressions to 2 breaths. Our compression rate is going to be at a rate of 100 to 120 per minute. If we compress too slowly, we don't get enough coronary perfusion pressure and cerebral perfusion pressure to actually get the blood circulating. It's very slow and does not have good cardiac output if our compressions are too slow. However, if we are compressing too quickly, we're not allowing the heart to completely refill. Therefore, we aren't getting the cardiac output because we don't have as much volume involved. Once we begin compressions, it's really important that we maintain them. This means we must minimize any interruptions. We want a compression fraction above 90% so that we stay on it every time with each compression, making each one effective. When we pause chest compressions, we see that perfusion pressure dip, and it takes a couple of compressions to get it back. So we want to try to keep it going as much as we can Again, only allowing for those quick pauses for breaths. If we have a provider that is doing compressions and they are not able to maintain efficient, effective compressions, then we need to switch. When doing those switches on the compressor, it's important to have a plan in place. Know who is going to be jumping in and taking over. Minimize urgency of transport in the initial phase. And what I mean by this is, let's get some high quality CPR going before we just try and throw the patient on the cot and load them in the ambulance. I know that this is a load and go situation. We have a very critical patient, but if we don't start getting some of that blood to circulate now, then that's going to affect the overall outcome of our patient. It's important to train as a team. It's important for people to understand the different roles involved in CPR and resuscitation. And it's important that you understand the tools that are available to you. The Lucas device is the one that we use. It provides compressions. This is a fantastic machine, and it's all calibrated so that each compression is the same depth, the same rate, and it's going to be very consistent. Now, when we are going to provide breaths for the patient, we are providing breaths at every 30 compressions, and we're going to give 2 breaths. Now, this is different in pediatric patients when we have 2 rescuers, and this goes to 2 breaths per 15 compressions, and that's simply because we know that pediatric patients have a higher resting heart rate and a higher resting respiratory rate, and for this reason, we need to make sure we're getting that oxygen pumped around quickly. Follow your local protocols for your ventilations and compressions. Again, most services use American Heart Association CPR guidelines. So those mechanical devices, those tools that we have that can help us, really do provide high quality compressions. The Lucas CPR device is the one that you will probably be shown in the classroom, or that is really used most often for services. We can stop CPR just long enough to put this on, and putting the Lucas device on really is fast once you are comfortable with it. You're going to slide the base underneath the shoulder blades of the patient just below the armpits. Apply the stabilization strap before trying to move the patient. And upon termination of arrest or return of spontaneous circulation, we've got to turn this thing off. We don't want to leave it on. If we were doing manual compressions, we would stop. Therefore, the Lucas device is no different. Another commercial device that's out there to provide compressions is the Zoll AutoPulse. I haven't seen this in person myself, so I'm not sure how many are out there, but again, this is going to provide compressions at a very consistent rate. We need to make sure that the patient is properly aligned. Provide your bag valve mask respirations or ventilations at 2 for every 30 compressions. Again, these machines have a setting for that. After 2 minutes of CPR, reassess, make sure, do we have a shockable rhythm? Our AED pads should remain in place during this whole time and will help us to identify when those 2 minutes are up for reassessment. Rapid defibrillation is extremely important if we've got an electrical component that has malfunctioned within the heart. The sooner we defibrillate, the better outcome our patient is likely to have. We're hoping to be able to reorganize the electrical activity so that the heart will begin pumping effectively on its own. Remember, with our AEDs, we need to turn them on and follow the prompts. Our AED is going to be able to recognize the cardiac rhythm, and if it is identified that the cardiac rhythm is ventricular fibrillation, VFib, or ventricular tachycardia, VTach, it will identify that a shock is advised. The defibrillator will charge its energy level, and when you push the button, after making sure everyone is clear of the patient, it will deliver a shock. Again, the AED identifies those rhythms, and the rhythms that we can shock in cardiac arrest are VTach and VFib. This is an image of an AED. AEDs may look different, but they all function the same way. It's good for you to understand that we do have two different classifications for AEDs. One is called monophasic and the other is called biphasic. It is not going to change the way that you apply the AED or how you shock the patient. This is strictly something that the machine itself will do. Monophasic simply means that it's only going to deliver a single shock, and that shock is going to travel from the negative pad to the positive pad that you've placed on the patient's chest. Now, a biphasic AED monitor is going to send the shock in one direction and then again in the opposite direction. Please understand with the basic and advanced life support systems here, the very basic function of compressions, ventilation, and hopefully defibrillation are the key tools that will potentially save your patient. If we can't do the basics, it doesn't matter if we can do any of the advanced skills, because the advanced skills themselves will not likely convert a cardiac arrest. Our AEMTs, also known as intermediates, and our paramedics have advanced skills such as IV access, medications, intubation, and these skills will help in the event of a cardiac arrest. But remember, those compressions, ventilations, and early defibrillation come first. So your book calls this the triangle of life, where we have one provider delivering compressions, one provider manning the AED, and the other provider is managing the airway and delivering the ventilations. So we have three providers forming a triangle, if you will, of life. The team leader may add advanced life support outside of the triangle if we have additional providers. Remember, we want to be able to swap out compressors every 2 minutes. If we have access to advanced life support with an intermediate or a paramedic, then we want to be able to work them into the equation so that the IV can be started, medications can be given, and other higher level skills can be performed if needed. So we're doing this very fine dance, if you will. Everybody's got a role. Everybody needs to work together, and if we all work together, then we're doing everything in our power to help the patient survive. The goal here is to get return of spontaneous circulation, also known as ROSC. This is where we get a heartbeat that is occurring on its own, and we get respirations that begin on their own. If we get return of spontaneous circulation, or ROSC, we've got to immediately transport this patient to an appropriate hospital that has an ICU that can help to manage their condition and get them stabilized. We need to make sure that we are keeping the airway open. We want to make sure that the blood pressure is maintained. Sometimes with advanced life support, that can be done with medications. We also need to make sure that the ventilations are adequate. Contact ALS, get them coming to you, get the tier going, whatever it takes. Be sure that you have suction ready at all times. We want to keep the airway open, and we may have some secretions that need to be removed. Getting a 12 lead is also helpful at this point so that we can identify the electrical activity that's actually occurring in the heart. Sometimes if we see abnormalities in the EKG, it may tell us that the patient may deteriorate if we don't do other measures. So that 12 lead will provide some useful information to the paramedics. So what are you going to do if you arrive and cardiac arrest is needed? Well, decide, are you the only rescuer, or are there multiple rescuers available to assist in the CPR sequence? Be sure that you are taking standard precautions, wearing gloves, maybe a face mask or face shield. Make sure that you are protecting yourself first. And then, do we have an AED? If there is an AED present, then we want to get that applied to the patient and have it evaluate what's going on as soon as possible. As soon as we identify that this is a cardiac arrest, it's a great idea to get ALS on the way. If they can meet us on scene while we are trying to run our cardiac arrest, then we may be able to improve the patient's chance of survival. Think about the tools that you have for ventilation. Your bag valve mask should be hooked up to oxygen. It should have a mask that fits the patient appropriately. And with our ventilations, remember, we're looking for rise and fall of the chest. Now, if we have a cardiac arrest, we're going to initiate CPR on scene, and then we are going to work to get the patient into the back of the ambulance. Lifting and moving these patients needs to be a coordinated effort so that we can do it without causing any harm to the patient or causing delays in compressions. Suction the patient's airway to maintain an open airway. Use your airway adjuncts. Either an OPA or an NPA may be useful using bag valve mask ventilations. And interview any bystanders or family members that may be able to give you some information regarding the OPQRST information. Remember, this is a coordinated effort. We are all going to work together. We have to switch roles from time to time because we want to make sure that our CPR is effective. So we want to be sure that we've got the appropriate personnel who have been trained to do these tasks. We are going to work very closely with our fellow EMTs, but also those ALS providers. Assign a team leader. Whoever is at a higher level of training should be the team leader. They should help coordinate all of the jobs for the EMTs or the emergency providers that are there. They will make sure that the compressions stay efficient and that we are minimizing any interruptions. We're going to look at the rise and fall of the chest with ventilations, and the team leader is going to be timing the 2 minutes in between each AED evaluation for a shock. So in cardiac arrest, we know that the BLS skills are compressions and ventilations are really the most important, along with early defibrillation. Sometimes this sequence may be adjusted based off of what's going on with the patient, the environment in which you are trying to do this. So we might have to make some adjustments, and that's okay. Just keep an open mind and use your critical thinking skills to identify what's best. So it's going to give you the steps here as we go through cardiac arrest and resuscitation. This sequence is in your textbook as well. But first of all, we want to identify that we have a cardiac arrest with this patient. We want to make sure that the team is ready to go and that we have individuals that are ready to begin in the jobs detailed to them. We want to call for appropriate resources if we need extra help. Begin those chest compressions and continue without pause as much as possible. Remember, if we're doing 30 to 2, we should only be pausing for 2 ventilations and then getting right back on the chest with compressions. Do not move the patient unless we absolutely have to. If the patient is on a soft surface like a bed, we do need to get them on the floor. performing compressions on a soft surface are not going to be effective. Get that AED hooked up. Remember, we can attach the AED pads while compressions are ongoing. So one provider should start the compressions while the other is attaching the patches to the patient's chest. If you're by yourself, put the AED on first, start compressions, and then follow the prompts. Here you can see we have the patient lying on a hard, firm surface. We've got one EMT in proper body alignment, ready to provide chest compressions, while the other EMT is getting the AED turned on and getting ready to apply the patches. Again, the AEDs may look different in appearance, but they all serve the same purpose and they all work very similarly. First, you have to turn it on, and then understand that the AED is going to direct you in what to do. We are going to place the pads in the appropriate locations. Usually that is on the right upper chest and the lower left kind of lateral placement on the rib cage there. We want to remove any jewelry or clothing, medication patches that may be in our way. If the patient is pretty hairy, trimming that excess hair is going to help our pads to adhere to the patient's skin better. If the chest is wet or sweaty, we want to try to dry it as much as we can so that, again, we get good contact with those patches. Stop CPR and allow the AED to analyze. If the AED says a shock is advised, during its charge phase, we can usually provide a couple more compressions. But once the AED says it's ready to shock, whoever is running the AED needs to be sure to clear the patient so that no EMTs are harmed when the shock is delivered. Again, clear the patient, tell everyone that you are getting ready to shock, and push the button. After the shock has been delivered, get right back into your chest compressions and resume CPR. We are going to continue that CPR for another 2 minutes, and after 2 minutes, we are going to allow the AED to reanalyze the patient's heart rhythm. This is a little bit of a kind of sequence or flow chart with resuscitation. It can be found on page 605 in your textbook if you want to take a closer look at it. It's just identifying we have an unresponsive patient, we've identified that they're apneic and pulseless, and then how are we going to go through those sequence of CPR. You can see at the bottom it identifies shock indicated or no shock indicated, and what steps we're going to take differently based off of the AED's recommendation. This picture is pretty good. It shows we've got one rescuer providing compressions. You can see the heel of one hand on the lower part of the sternum. The fingers are interlocked and the shoulders appear to be right over the sternum to allow the hips to be the fulcrum, and good compressions hopefully will occur. The individual that is running the airway is at the head of the patient. They are maintaining that EC grasp on the patient's mandible and the mask. The mask properly fits the patient from the bridge of the nose down to the chin, and you will see that it is hooked up to oxygen and the bag there is being squeezed to provide ventilations. CPR is about good teamwork. We've all got to work together, and for those 2 minutes between analyzing with the AED, we've got to perform good chest compressions and good ventilations in order for our patient to have the best outcome. ALS, or advanced life support interventions, may be appropriate, but again, we've got to ensure that these are being done by someone who has the proper training. As we're talking to those individuals that might be on scene, whether that's friends or family, We want to try to get a history. We want to know about what's going on here. What's the history of the present illness? And we're going to do that secondary assessment, kind of that head to toe, looking for any other physical red flags that may tell us why the patient has gone into cardiac arrest. Having family present during resuscitation is kind of a touchy subject. Some family members may have a better understanding of the effort that we put into the resuscitation if they watch, but some family members will not tolerate watching the resuscitation and therefore may need a great deal of emotional support, in which if we don't have the rescuers available to take that person aside, then it's probably better that they leave the environment or leave the scene. If we get ROSC, let's shift to post-arrest care, and we really want to focus on getting the patient transported to a facility that can assist in stabilization. We want to ensure that the airway continues to remain open, and if rescue breathing is needed, continue that rescue ventilation. We do want the patient to get access to advanced life support as soon as possible. During our transport of a patient who has gotten ROSC, we want to continually reassess the patient. This means we're going to do a pulse check every 30 seconds. If no pulse is found, we can stop the vehicle, we can resume our CPR, and use our AED to identify the rhythm and possibly shock the patient again if needed. Now, if you have ample rescuers, you may not need to stop the vehicle. Most services are going to have 2 rescuers, and one of them is going to be driving, the other is going to be in the back with the patient. If you do not stop, that leaves the CPR sequence up to 1 rescuer. We know we're much more efficient if we have 2, and that is why it suggests that you stop. Terminating resuscitation is only going to happen for a handful of reasons. One of those would be if the patient regains spontaneous circulation and or spontaneous breathing. If we have spontaneous circulation with not life-sustaining breathing or respirations, then we need to ventilate the patient with our rescue breaths. If someone is going to take over for us, then we can stop. It doesn't mean that the resuscitation itself has been terminated. It just means that you are no longer providing those compressions at this time. You may rotate back in. Now, that person who's going to take over for you needs to be of equal or higher level of care. Now, if you're doing compressions, anyone trained in CPR can do that, but during your transport, you must remain with the patient or turn the patient over to a higher level of training, which would be your intermediates or your paramedics. If you are absolutely too exhausted to continue, then our compressions are not going to be effective and it's not going to be worthwhile to continue CPR. And if we receive a cease resuscitation order from a physician or other authority, like our medical control, that may be given to us because we've been running the code for a long period of time. Maybe they've identified some new assessment findings that tell us that our resuscitation efforts are meaningless. But again, only these handful of reasons should we stop our resuscitation. One of the most difficult parts of our job sometimes is telling the family, the friends, that our efforts have been unsuccessful. So unsuccessful resuscitation needs to be communicated to the family, and in doing so, we need to be straightforward and direct. We need to use the term died. We need to allow the family time to see the patient during this period. Be patient with the family and understand they may be tearful, they may be angry, they may be in denial. There are many feelings that may come about during your time here with them. Just try to support them, provide them reassurance that everything was done, and do not tell them you know how they feel. Understand that we can be empathetic. We understand that this is a difficult time, but we do not know how they feel, and families will sometimes feel that you are minimizing their love for the patient, their concern for the patient, or their grief. Be yourself. Try to be comfortable. Don't be fake or false with the family. And again, present the facts. Some other things that you may want to consider in some resuscitations is that sometimes these patients have been defibrillated before we even get there. If we are walking in and CPR has already began and the AED is already in place, we want whoever is running the AED to continue that process until they're at a good stopping point for us to take over. If the AED is already in place and the patches are on, we do not want to waste time trying to hook up a new AED. And remember that the electricity that is delivered with each shock may vary. And so we want to keep the AED that was placed on the patient first and continue with that AED, even if it means taking it with us. Your protocols will tell you how and where these transports need to go, but make sure that you have an understanding of that, as well as your normal basic steps for life support. Think about resuscitation in an ambulance. Now, when you're in the back of an ambulance, it's very difficult to identify when the ambulance is going to be turning left or right, or if the ambulance is going to hit a pothole or need to slam on the brakes. This is why we really try not to run these codes in the back of an ambulance. If the ambulance is moving, injury to us, the emergency responders, can occur. When providing patient care in the back of an ambulance, it is suggested that you wear your seatbelt. It's going to be impossible to provide compressions if you have your seatbelt on. If the patient does go into cardiac arrest during the transport, after ROSC has already been gotten, or maybe they go into cardiac arrest in transport and they were not that severe on scene, then we need to make sure that we're able to perform adequate CPR and get our AED turned on and placed. This means stopping the ambulance and having our driver or extra help be in the back of the ambulance to assist us. Something to think about this time of year when it's cold. Hypothermia is an issue, and submersion in water can be a concern. These can cause cardiac arrest, and understand that there are some limitations based off of the patient's situation. So if the patient is hypothermic, then we only want to attempt defibrillation once. If our AED says it can shock, we're only going to do that once because we need to get the core body temperature up before defibrillation will really take hold most of the time. Do not terminate your resuscitation efforts though. We want to continue good CPR. We just cannot shock the patient. In a submersion injury or with a drowning victim, we're going to do our cardiac arrest as we normally would with CPR and hooking up our AED. But keep in mind, if we have a submersion, there may be fluid in the lungs. So we want to manage the airway very carefully. We want to be aggressive and keep the airway open, providing our ventilations appropriately. We may want to have suction available, and we want to try to defibrillate the patient in a safe environment. So the patient should not be resting in water. We should try to dry the chest, as we mentioned earlier, but taking these steps are going to give our special consideration patients a better chance at survival. Yes, I already said it. Do not defibrillate a soaking wet patient. Dry their chest, move them out of the wet environment, and remove any medication patches that may be on them. Patients can wear medication patches for a variety of reasons. Some are for pain medication, some are for cardiac drugs, some are hormones. So if there is a patch of any kind, it needs to be removed. Be sure you are removing it with a gloved hand. Otherwise, the medication can be absorbed into your skin. But this medication patch, if the patient is defibrillated, can cause a burn at that site. You are going to find that people may have implanted devices in their chest. These may be pacemakers or internal defibrillators. Yes, we can still use our AED on these patients. We just want to be sure that we are positioning our defibrillation pads to avoid contact with the device. Most of these devices are going to be on the left upper side of the chest. However, they may be implanted in different locations based on the patient. So take a good look at the chest when you're applying these patches to ensure that you are putting them in the right position. You can see a picture on page 615 of your textbook of a patient with an implanted pacemaker. Again, many of those implanted devices are going to include a pacemaker, an implanted defibrillator, a ventricular assist device, or a cardiac bypass surgery. Now, a ventricular assist device is called a VAD, and these are actually very unique in that they hook up to a battery pack that is outside of the body. If you see this, the family should be able to provide you with additional information regarding the patient and their condition. Okay, so we understand cardiac arrest is when the heart stops functioning. This may be caused from VFib, VTach, asystole, the flat line, or pulseless electrical activity, which is random electrical impulses traveling through the cardiac muscle, but these impulses do not cause contraction of the heart. With cardiac arrest, we get an immediate drop in coronary and cerebral perfusion pressure. This means that the heart and the brain are not getting oxygen. We understand that if we do not get oxygen to these organs within a short period of time, the patient can have devastating consequences. Acute coronary syndrome is the most common cause for cardiac arrest, but some cardiac arrest can be asphyxia caused, and this is likely to be most common with pediatric patients. Cardiac arrest is usually recognized with an unresponsive patient who is not breathing and has no pulse. We want to follow that 5 steps in the chain of survival with recognition and activation of the emergency response system, high quality CPR, early defibrillation, our basic and advanced emergency medical services, and then our advanced life support and post-arrest care. Resuscitation is not likely to be successful if we do not work together as a team and have quality management to ensure that the compressions and ventilations that we are providing to the patient are done correctly. So we talk about what's most important here, and it's back to the basics. It's those high quality chest compressions and ventilations that provide rise and fall of the chest. The AHA, or American Heart Association's Chain of Survival, talks about these key elements, and you guys have already done this with your CPR class, so just think back to that course and what you were learned and how the process flows. There are tools that are available to us to assist in CPR, such as our Lucas CPR device or our Zoll AutoPulse. An AED will help with early defibrillation in those patients who have been identified as having VTAC or VFib. And don't forget, post-cardiac arrest care is essential if we want to prevent the patient from going back into cardiac arrest. When the AED has identified that a shock is recommended, how are we going to clear the patient? This is going to vary depending on your preference. You can say shocking on 3, 1, 2, 3, push the shock button. You need to make sure that everyone is away from the patient when you do in fact push the button. Otherwise, pause, do not push the button, redirect those individuals to clear the patient and attempt your clear phrase again. What are some things to think about when you're going to use the AED and how are you going to use it? We need to make sure that the patches are going to adhere to the patient's chest. So if the chest is wet, if there are medication patches there, if the patient has a lot of hair on their chest, we may need to do something about those things. Remember, the AEDs look different, but they all work the same. Turn it on and follow the instructions. Okay, let's think about this. We've got a 78-year-old man who's been complaining of some shortness of breath. They have called 911 and dispatch has notified you of the address and sent you to see the patient. When you arrive, however, you find that the patient is unconscious. They are not moving. What are we going to do? Hopefully we can act quickly. We can identify if the patient has a pulse or if they are breathing. We want to begin high quality CPR if the patient does not have a pulse. We're going to do compressions and ventilations at a ratio of 30:2 with compression rate of 100 to 120. We want to find that AED and get it applied to the patient's chest as quickly as possible. We want the AED to analyze the rhythm, and we want to deliver that shock as quickly as possible if it is recommended. CPR should be restarted as soon as the shock is delivered or once the AED has identified no shock is advised. We want to continue to run this code using high quality CPR. Hopefully this chapter was okay for you. Resuscitation is a big part of what we do, and that is the end of chapter 21.